to side anastomosis to the infrarenal aorta, and 2 limbs tunneled behind the colon, the right colon on the right, the sigmoid colon on the left, going to bilateral common femoral arteries. So he had an aortal bifemoral bypass with bilateral common femoral endarterectomy and did quite well. Was discharged about 5 days later. We saw him back in clinic 2 weeks post-op, and he had no more claudication, palpable pedal pulses bilaterally, and he was working on smoking cessation. We saw him 4 years later. He was still doing well, no claudication, palpable pulses, normal ABIs, and still working on smoking cessation. So my point here is that aortal bifemoral bypass is very durable. I usually tell patients that this is the most durable bypass we'll ever do. Probably 85 to 90% patency at 5 to 10 years, which is very good for vascular bypasses. In addition to the bypass, however, we do have to stress good medical management in these patients. They have to take their aspirin, statin, and stop smoking. Of course, success of these cases is predicated on good patient selection. Not all patients are good for aortal bifemoral bypass, as highlighted by this second case. So this is a patient with right foot ischemic rest pain. He also didn't have a lot of cardiac risk factors, actually, but he had other problems. He initially presented to an outside hospital with bilateral lower extremity ischemic rest pain, and he had multiple previous abdominal surgeries. He had scars in all directions, in all quadrants of the abdomen. So basically, he was prohibitive for another abdominal surgery. So at the outside hospital, he underwent right axillobifemoral bypass. So this is another option for surgical revascularization for aortoiliac occlusive disease. It is extra anatomic bypass, so generally lower graft patency than inline reconstruction, but a perfectly good option for someone who has a hostile abdomen. He did this surgery outside, but came back to us about a month and a half later with recurrent right foot ischemic rest pain. His abdomen was significant. He was actually very thin, quite cachectic, but his abdomen was completely scarred, scars in all directions, all quadrants. And he had an absent femoral pulse on the right. ABI was 0.2 on the right, 0.6 on the left. And this is a 3D reconstruction of his CTA. And you can see on the right side here, this is his ax bifem, the right limb coming down. This is the right to left cross femoral bypass here. And then it looks like there's an empty space here. And that's because the right limb of the ax bifem is severely diseased, and the outflow to the right side was severely diseased. There was a fair amount of calcified disease in the distal right common femoral on the origin of the profunda. And when we scanned his chest, we found a pseudoaneurysm at the right axillary artery, probably a clamp injury from his previous surgery. So this is the axillary cuts from his CTA. So the ax bifem, the right limb, is on the right side over here. You'll see that come in here, right there. He actually has a thrombosed small aortic aneurysm, but you can see that the infrarenal aorta here is occluded, as are bilateral iliacs, and there is a severe stenosis of the distal right common femoral and then the patent cross femoral bypass. And then here is very hard to see, but there is a pseudoaneurysm of the axillary artery on the right. So what do we have here? A patient with a hostile abdomen, poor candidate for aortal bifemoral bypass. We actually did consider doing a thoracobifemoral bypass on this patient, which is another good option for inline reconstruction to both legs, but rather having an inflow from the abdominal aorta, you can take the inflow from the thoracic aorta. Perfectly good inflow source, except that this patient had PFGs done and he had pretty significant restrictive lung disease, so probably not a good idea to do the thoracotomy here. And we had to address the right axillary pseudoaneurysm. So we decided that we would fix this, establishing inline flow to the right by recanalizing the right iliac system and then preserving the right to left fem-fem bypass. So we did this in a pretty extensive procedure. We did it all in one day. We did a right common femoral endarterectomy and profundoplasty, followed by recanalization of the infrarenal aorta and right iliac artery. We worked bidirectional. I'll show you the pictures in a minute, and had a wire that was externalized from the right axillary axis out the right groin. We reimplanted the right to left fem-fem bypass. We covered the right axillary ax bifem inflow with a Viabon, and we did a sartorius flap in the right groin. So here are some pictures. So you can see here, these are the clamps from the common femoral endarterectomy that we did. We started with a wire from the retrograde, from the right common femoral, and a wire coming from above the right axillary axis. And we did this with a 12 French sheath that was telescoped over an 8 French sheath. And through this, we had a navicross catheter and a glide wire, which eventually we basically pushed through the aortic occlusion and into the right iliac, and then externalized out the right groin, which was open because we did the common femoral endarterectomy. We didn't have to look for some other plane or whatnot. It was just open. So the wire came out, we externalized it, and then we were able to IVUS over it. So we did IVUS here. We ran the IVUS catheter through our through wire to identify the level of the renals. We wanted to make sure that the stent, the top of the stent, would be in the patent aorta. And then we deployed a series of VBX and Viabon from the aorta right at the level of the renals down into the right groin, post-dilated it, and here are our completion pictures. So you can see here, there is basically just a channel from the aorta right at the level of the renals coming down into the right groin. You can see here, there's a little bit of stenosis at the distal aspect of our blast Viabon, but the femoral patch looks wide open, as is the profunda outflow. So we added another Viabon distally, which looked fine, that fixed that problem. And then we looked at the pseudoaneurysm. We pulled the sheath back. The 12 French sheath is here. We pulled it back into the axillary artery, shot a picture here. Here is the pseudoaneurysm of the axillary artery. This is the inflow of the ax by fem. We covered that with a 10 millimeter Viabon. And then this is his post-op CTA. He actually did quite well from this. His pain improved. The right groin healed without any problems, thank goodness. And his post-op ADVI is good, 0.7 on both sides effectively. So he did well, and I think from this, we learned a couple things. Utilizing bidirectional crossing with good distal sheath supports, having that 12 French sheath telescoped over the 8 French sheath was really important to be able to get through the occluded infrarenal aorta. Axillary cut down, I think, is actually really important too, because it allows us to be more proximal in the arm. We don't have to worry about the length coming from the radial artery, and we can have a nice big sheath up there. Externalizing the wire through the open common femoral artery obviates the need to rendezvous in a occluded segment, and then we can have through and through wire access. And IVUS, very important to identify where the renals are and to make sure we're in patent aorta for the proximal stent. So I will end there and ask for any questions or discussion. I have another case if there are no questions.
A fantastic case. We'll get our discussion started. I have one question. It could be very naive. However, why didn't you consider this option on the right side before the extra anatomic bypass? Was that not an option before?
He came to us with the extra anatomic bypass.
It was not
yes,
done then.
It was. So I mean, I think there are many ways to skin a cat in this situation. You know, this is a patient. He was actually very frail looking and really should not have gotten an aortobifemoral bypass. With that anatomy, if you look at the CAT scan, the first thing you think is he should get an aortobifemoral bypass. But given how he looked in all of his previous surgeries, perfectly reasonable to do an extra anatomic bypass in this case. So he actually came to us with the right ax by fem.
I see. Comments from the audience and panelists? Bala, you are the surgeon amongst us. Sorry, Dmitriy, continue, please.
No, I was just going to say that this is an excellent case and a great example of how hybrid skills are used, both surgical and endovascular. Because yes, potentially you could have done the whole case endovascularly with the axillary access and the treatment of common femoral, but long-term wise and access-wise, doing a surgical cut down both in the common as well as an axillary, I think is what allowed for an excellent result here and long-term good result.
I agree, and anytime we see these kind of aortic occlusions, it's always better to try to get inline flow through the aorta rather than an extra anatomic source. Axillobifems have a very low patency. It varies per study, but it's like 30% to 50% over 5 years. Aortic bifemoral bypasses have like 85 to 90% patency in over 5 years. So it's always better to use the aorta as the source of inflow if it's possible for aortic occlusions. So that's why we considered, I think, appropriately doing inline flow through the aorta.
I'll say that when we were crossing the aorta, it was not guaranteed that we would come out the right side. Because as you can see, the aorta was occluded, as were both iliacs. I cut down on the right side to begin with because I knew there was right common femoral disease that was going to have to be fixed regardless. But if we had gone down the left side, I would have had to cut down on the left side too. So I had planned to go down the right side, and we were lucky to end up on the right side. But had we gone down the left side, I would have just opened the left side and then externalized the wire on that side. We would just end up with bilateral groin cut downs as opposed to one.
Yeah, so great case. Could you just touch real briefly on, for those in the audience that aren't surgeons, just a quick list of the type of patient that you would send for AXE-BiFem? And the reason this comes up is I saw a patient in the office recently, his EF was 20%, he was super sick, had horrendous claudication, couldn't walk across his house, and everyone kept telling him no option, no option, no option. I sent him for AXE-BiFem, and he did very well. And so if you could just talk about the kind of patient you send for that surgery.
Sure. I think exactly that type of patient, high cardiac risk, because the aortic cross clamp is a pretty big stress for somebody with significant coronary disease, especially if their EF is marginal. I would say that you have to really think about doing an AXE-BiFem or extra anatomic bypass on someone who doesn't have a limb-threatening problem. So, for wounds, yes. For rest pain, probably, but the thing is, the AXE-BiFem doesn't have great patency just because it's extra anatomic. If you think about it, it's probably like a 6 or 8 millimeter tube going from the arm to the leg. It's not like intuitively the best thing. So I think it will help heal a wound, but in somebody where you're going to be struggling with rest pain or claudication and it's going to be a chronic issue, I don't think of it as a really long-term solution.
All right, thank you very much. Great job. All right, moving on to the next case. Will be Dr. Soga, endovascular approach to aortoiliac occlusive disease. Thank you.
Before Dr. Soga begins, I do want to add that Dr. Soga is a master operator, and those of us who do endovascular intervention follow his work from Japan for last many decades. And Dr. Soga, you've taken a long trip to come to us, and all of us in this audience are really privileged to have you here. And if you need to go over some time, please feel free. We want to hear as much as possible from you. Thank you for being here.
Thank you very much. Thank you very much. Good afternoon, everyone. I'm Soga, interventional cardiologist, came from Japan, all the way from Japan. Thank you very much for taking time. So today, my topic is here, so endovascular approach to the aortoiliac occlusive disease. Sometimes it's a very tough lesion. Here's disclosure. Okay, sorry for back. Let me explain the Japanese trend for the endovascular procedure for aortoiliac disease. So mainly, more than 80% the bare nitinol stent was used in Japan as well. The remaining, the 20%, the 10% is a stent graft for the iliac. The remaining 10% is a standard PTA. So different from the actual practice of US, the 80% of endovascular procedure in Japan was performed by interventional cardiologist. The remaining 20% was performed by interventional radiologist or vascular surgeon, but mainly interventional cardiologist performed the endovascular procedure. So also, including me, we love the IVERS, the transradial, and the monorail system. Therefore, so in Japan, the Japanese procedure for aortoiliac lesion, so mainly performed from the transradial. Concretely, so we can use the, such like that. So sometimes there are some concern about the radiation exposure, but we put the seal against the radiation between the X-ray and the operator like that. Here's the first case, 80-year-old male. He had the left iliac occlusion. I inserted the guiding system from the transradial. Then I advanced the 035 guide wire, whether neck wire technique like that. With the separate catheter, I just pushing the 035 guide wire. Then luckily, in this case, crossing the lesion anticoagulatory, if failed, I usually inserted the retrograde small cyst or just only microcatheter from the retrograde. Yeah, now the balancing the guide wire, luckily crossing the lesion. After the guide wire passage, standard balancoplasty was performed to cover the whole lesion. Then I put the stent to cover the bare-nitinol stent. You usually mainly put the smart stent after the post-dilatation was done. The balloon catheter has also a long shaft, therefore there is few radiation exposure concern, I think. That's why, so this case, I succeeded the procedure from the transradial. So amazingly, after the procedure, it's a big issue, that he got up by himself and go back to his ward on his foot. It's a very good point. It's easy. So nurse or medicals, it's easy to manage the patient compared to the femoral axis. So even in the coverage stent, so we try to put from the transradial. Here is a eccentric calcified common iliac stenosis. That after the guide wire passage, I dilated was a balloon. After that, deep engage was performed. Then I tried to insert the covered stent. In this case, I tried to put the live stream 7 by 26 millimeter because this is only 6 French compatible stent. Therefore, I try to, yeah, this is the precise positioning. Then I dilated the stent. So for such like eccentric calcified nodular stenosis, there is some concern about the vessel rupture. Therefore, I often choose the covered stent like that. But 7 millimeter covered stent is very small compared to the normal reference vessel. Then after that, it's a 10 millimeter post-dilatation was performed from the transradial like that. This is the last string. That 10 millimeter post-dilatation, so good angiographic result was obtained like that. Then I finished this procedure. Of course, this patient going back to on his foot. Another case, the bilateral CIA stenosis and occlusion that I treated was BXB, 6 French compatible for the both side. Initially, for the right side, I tried to put the BXB VVX gore. Does not move. This is a positioning, the precisely. I initially dilated the BXB on the right side. Yeah. Then after that, so same way, so to put the BXB for the left common iliac artery, precisely. So that's not pushing up the BXB. The precise positioning is very important. from transradial. So simultaneously, we treated with a common iliac artery like that. Of course, I do not perform the transradial approach in all cases. So I usually avoid the shaggy aorta or the history of the stroke. This patient, I avoid to try the transradial approach. But the other patient for stenosis, even for CTO, I attempt to perform the transradial approach. So as you know, transradial aortoiliac endovascular procedure does not increase the perioperative complication compared to the femoral axis. Therefore, we try to use the transradial approach. But dialysis patient, so involving the fem-pop lesion, sometimes we choose the femoral axis contralateral approach or something. Thank you. Thank you very much.
Dr. Soga, we have quite a few questions for you.
Thank you very much.
I'll hand it over to my colleagues. Dmitriy, you have a important one.
Yeah, one question was, can you give us some advice and guidance how you choose and size the stents and the post-dilation balloons? I presume some of it is based on lower profile, so you undersize it intentionally. But can you talk about that?
Thank you very much. So basically, the first guiding catheter, I usually use a Radian system, 1 10 centimeter, or a Terumo R2P system. The pre-dilatation was 6 or 7 millimeter, just making a hole to cross the stent. Then I put the stent. The stent is 8. For external iliac, the 8 millimeter. That common iliac, 10 millimeter smart stent. If I put the bare nitinol stent, if I put the covered stent, 7 by 26 or 7 by 29, the BXB or something. Then after that, I adjust as a post dilatation against the reference vessel diameter. Is it correct? Does it make sense?
I guess my only concern of transradial approach for calcified iliac CTO specifically, obviously, is if, God forbid, you have a perforation, by the time you get access from the femoral and put in an aortic occlusion balloon, it could be too late. That patient could literally exsanguinate within a few minutes. So I guess that would be my only concern about transradial for calcified iliac CTOs. And we've obviously been very pleased with and very enamored with the results of intravascular lithotripsy, especially with the L6 devices, where we can get a great result. For example, that second case that you showed, that left common iliac, I mean, of course, you can put a VBX in there, but there was still probably about a 30 to 35% residual stenosis. So I guess in my mind, I'm wondering, that case in particular, why not just go left retrograde with a 7 French sheath? You can put in an 8, a 9, or even a 10 millimeter IVL and be able to get a really nice full expansion. So if maybe you could just comment about what your approach would be if, again, heaven forbid, you had an issue with a perforation by coming from a transradial. Is there enough time, or do you have an aortic occlusion balloon that you could place that would fit through a 6 French sheath coming from a radial access?
Thank you very much. That's a good question. So in Japan, the patient age is much elderly, maybe, so more than 80 or 90 patient. So it's not easy to supine position, to keep the supine position. Therefore, so usually I choose the transradial approach. But as you mentioned, so for femoral access, it's easy. So for short time saving, but that's why I choose that. So 20% or 30% radial stenosis, it does no matter because the restenosis rate is very, very low for the iliac lesion. So as you mentioned again, for the vessel rupture, regarding the vessel rupture, so a little bit smaller size post-dilatation, it is no matter. There is no concern about the rupture. Therefore, I attempt to such like a procedure.
Okay, got it. I think I finally figured it out on Friday that the microphone has a button. But I want to ask that, Sanjum, so tell us, do you guys do radial procedures for peripheral endovascular and then strategies? And do you have all the tools that the magnificent sheets and balloons that they have in Japan?
So we do actually have we start radial first actually on quite a few number of patients, and we do use it quite frequently, and we do have all of the same technologies which he's illustrated here beautifully in how to use them. I think our challenge is sort of, I'll be honest with you, I was doing it more and I've actually started doing it less because of some of the things that Peter has brought up in terms of calcium modification strategies and having appropriate size covered stents should you run into a problem. Now that Gore has released a 6 French version of VBX, I think that allays some of the issues. And I think for iliac, a lot of our femoral toolkit will work, but when you start looking at below into the femoral popliteal segments, that's when you start worrying about catheter lengths, and that can also be a challenge, especially even down to the common femoral in a tall patient. So,
Dr. Soga, I have a provocative question for you. I will ask my panelists and many interventionists in the audience just to raise your hand if 014 or 018 is your primary wire for aortoiliac occlusive disease. Dr. Javier says no. Mine it is actually. The reason, I'm just saying, and we see that trend slightly increasing. Dmitry, what about you?
Transfemoral are usually 035.
Yeah, but I'm saying is that the Japanese smaller caliber wires are so good. And so have you ever used, or anyone does, or we are an exclusion, a rarity of using smaller caliber guide wires? Tarek, you want to? And I know Dr. Soga runs a very powerful and impressive Japanese registry, and we have our own. We see that trend slowly creeping up because the lower profile guide wires with the support catheter work very well. So comments and agreement, disagreement. Peter, you have a comment first?
Yeah, I was going to say that I think it depends on what you're intending to do. So if, for example, that patient has common femoral disease where you may be contemplating doing IVL and a DCB. So in that situation, why not just go straight to an 018 and you could potentially do everything over that 018 wire. So I think it depends on the indication. If you're only going to be doing the iliac, it's a different story. But again, as I mentioned earlier, we're doing a lot more IVL. And so if we're endeavoring to use an L6 device, we'll probably go ahead, do all the vessel prep with that, and then typically have a great wide open lumen, and then it's very easy to then just go ahead and keep that wire in there and go ahead and put your stent in.
Dr. Soga, your comments on the caliber of the guide wire, or it is predominantly 035 in Japan?
Thank you very much. So usually use 014 or 018. So especially I use the IVERS, therefore 014-inch guide wires usually, but no problem. So backup force or delivery, any other things, it's no problem in my procedure. So also transradial approach, saving the time for the patient, not saving the time for the doctor, but saving the time for the patient. It's a very comfortable patient appeal to me. Therefore, I believe that it's very good for treatment for the patient.
Thank you.
Thank you very much.
So one debate for the radialists is right radial or left radial, and I tend to go left radial. I want to know what Dr. Soga's approach is generally.
Dr. Soga, left or right radial?
I prefer the left.
Yeah, as do I, but the back sometimes can differ.
Great job. Moving on. So our next case will be a surgical approach to common femoral artery disease, and this will be presented by Dr. Ramanan.
Thank you.
Thank you for the opportunity to present. So I have several cases, and I'll go through as many as I can as time allows. So the first one's a 75-year-old male with a right lower extremity rest pain, standard comorbidities. He had heart failure, an AFib, and some VTAC and an ICD. Those are his toe pressures and ABIs. And this is his CT scan. So this is just a standard common femoral lesion, and our clinical challenges were he had a concomitant iliac lesion. So in a patient with rest pain and no wounds, should we treat this with just all endovascular, or should we do a combination open and endovascular approach? Should we treat just the iliac lesion and leave the common femoral disease? And does the SFA occlusion, which he had in the CT, need to be treated at the same time? So we did a hybrid approach where we basically stented the external iliac and fixed the common femoral artery. In general, our approach for common femoral disease is to treat it with open surgery, and then we'll treat the SFA or iliac lesions endovascularly if possible. So our learnings from this case was the preoperative CTA is actually really key to determine management of patients with inflow disease as well as common femoral disease. And common femoral endarterectomy can be performed safely even if patients are pretty high cardiac risk. And I've done several of these under just block and MAC if they're really high risk. So even with high cardiac risk, they can be done safely. And treatment of the outflow disease is not always necessary for patients with simply rest pain. This is a 69-year-old male who had right groin pain after an EVAR that I did. And he actually had a recent COPD exacerbation at an outside hospital, and he had had a pneumothorax that required a chest tube placement. He had a CT done at that hospitalization that revealed a large aneurysm, so he came in for surgery to us. He underwent the EVAR about 1 month after his pneumothorax. And then 2 days after the EVAR, he had a severe coughing episode and complained of groin pain. So because he had groin pain and we examined him, didn't really find anything significant. However, the CT scan showed a very large pseudoaneurysm of the common femoral artery. So, this is, again, a pretty high-risk pulmonary, from the pulmonary standpoint patient, and putting him under anesthesia, again, would be bad for him. However, so we considered what are the approaches we could try. Should we do endovascular, where we put a Biobon in his common femoral and cover the pseudoaneurysm? Should we try thrombin injections, or should we approach this by open surgery and fix the pseudoaneurysm? And given if we decided to do endovascular, what should be his access, because he has an EVAR now? So initially we tried thrombin injection. However, he had a pretty wide neck, and so this was a very high flow aneurysm, pseudoaneurysm, and we could only get it to thrombose partially. So in him, we chose to do open repair. And the reason we chose to do open repair was because his pseudoaneurysm was coming off very close to the femoral bifurcation. So the only way we could treat it endovascularly would be to put a stent all the way into the SFA and cover his profunda. And so we decided to do it open. So the key learning was preservation of the profunda is very important for the leg. It's the most important artery in the leg. And so that's what determined our approach to treating this. And success and ability to perform a thrombin injection depends on the length and width of the neck of the pseudoaneurysm. And it's important to get imaging for access complications when a patient complains of groin or leg symptoms after an intervention. So this is a 50-year-old female who had left leg short distance claudication and rest pain and numbness 1 week after a TVAR that was done 1 week prior at another hospital. So she had gone in for a penetrating aortic ulcer, and she also had an embolectomy of the SMA at the same time as the TVAR, and she was on anticoagulation. We did an ABI, and she obviously has low ABIs on that left side, which is the access side, so we got a CTA. Okay, so that's her TVAR, and then she had severe stenosis, moderate to severe stenosis of her external iliac, and her common femoral was occluded. So we did a left femoral endarterectomy. What we found was the Perclose device that had been used had tacked the back wall of the common femoral artery. And I know this is a pretty common complication. A lot of us have faced this. However, she didn't have a good pulse after completion of the femoral endarterectomy. So then we did an angiogram and found the iliac stenosis and treated that with a stent. And her ABIs got better. So I think pulse exam is really important after any kind of a vascular access to recognize an access issue. And new leg symptoms should prompt a workup for access site complications. And the underlying chronic external iliac disease was initially thought to be unremarkable, but when the pulse exam was poor, we had to address that. And I think it's important to keep in mind that more procedures may need to be done after treating the common femoral disease. Thank you.
Great job, great presentation. Let me ask the panel, these cases are kind of special and sort of related to complications from other procedures, but in run-of-the-mill common femoral artery disease, has the use of IVL changed how you approach common femoral disease, or is surgery still your primary mode of treatment?
I'll take this one. We actually published a paper in CRM 2 years ago on our experience utilizing a combination of atherectomy, IVL, and DCB specifically for common femoral disease. The majority of those patients were Medina 111, had excellent results with a TLR rate of only 16% after 2 years. And interestingly, what we found in the study was that initially, when we first started using IVL, we were still in the learning phases of what IVL could and maybe couldn't do. So we tended to do atherectomy followed by IVL, and then when DCB came along, we ended up finishing up with a DCB to try to get a better long-term, more durable result. And with serial ultrasound, what we found was that the overwhelming majority of the acute luminal gain was from the IVL. And we soon sort of realized that we could save a little money and a little time by kind of dropping the atherectomy part and then just going directly to IVL and DCB. So for patients who don't have really horrible exophytic disease, I think that's a very good alternative treatment, particularly if a patient presents to be a high surgical risk for whatever reason, either anatomic or because of medical comorbidities.
Great, thanks, Peter.
I want to ask Dr. Soga, tell us about how is common femoral artery generally approached in the Japanese
Thank you very
areas?
much. For isolated calcified common femoral artery, as a first-line treatment, endarterectomy. But the other, so continuous plaque involving the proximal SFA or external iliac, I try to open by endovascular.
I see. I mean, my personal bias, and because before you ask a question, you have to announce what you believe, but I would say that if the presence of profound femoral disease, especially proximal and downstream, that still biases me. I'm sure Drew will convince us otherwise, away from endovascular. So generally, I tend to stop and take stock. Sanjum and Dmitriy, please.
I think, as was mentioned, yes, the anatomy is important, whether it involves the external iliac, the SFA, the profunda, but also, as was mentioned, the comorbidities, the age, and the patient preference goes into it. And I think, prior imaging with CTA, for instance, will give you a good idea of whether both options are feasible, and that should be an important discussion with the patient.
It's an ongoing discussion with our vascular surgery colleagues. I think what Dr. Ramanan didn't show us was some of the pictures that I get of the calcium and the sort of that deep stuff that they're able to get out with endarterectomy. As much as I agree with Peter, for the high-risk patient, IVL has been a game changer. We don't have the endovascular tools to take out those bulk, dense rocks that sometimes are there.
Bala, you can tell us, what's your approach and how frequently you use IVL. That was Chris's original question, but also emphasize how frequent is truly in real life the use of femoral endarterectomy under local anesthesia or block. I mean, I hear it more often than I see it.
So it's not my preference. It's actually really hard to do an open surgery on somebody when they're awake. However, if someone is very sick, like, very bad cardiac disease or pulmonary, sometimes it's a pulmonary problem. And if their body habitus is good for open surgery and they are cooperative, because those are all important when you're doing an awake open surgery. So you have to have a cooperative patient, you have to have a good anatomy, and if their physiology is bad, that's when I do these under block. It's not my preference. It's actually really painful for the surgeon to do it. So I prefer to do it under general anesthesia unless the patient is sick and cannot tolerate, general anesthesia.
Again, to put you on the spot, what is that number? 5%?
Probably, 5% or less. Yeah, it's not common to do it under
Javier,
local.
you are our premier vascular surgeon. Is it true for us too? It's under 5%, 10%? What is the range of truly local anesthesia or block-based femoral endarterectomy? I am. No, thank you. And this is an important question because this is sometimes that number is not known, and we are not setting up Drew for success here. But I think, Bala, thank you very much. I want to invite my dear friend, Andrew Klein from Piedmont, to speak on endovascular approach to common femoral artery and take no leads from our previous discussion, Drew.
It's taking me to Friday to figure this out as well, buddy. So we're going to talk a little bit about common femoral intervention here and some technical aspects of it. And I'm going to start off with a couple cases. No conflicts of interest. So this is my first common femoral arterial case without, just a few months after I left fellowship many, many moons ago when I had hair and it wasn't gray. And so this was Rutherford class 3. I referred the patient to surgery. Unfortunately, due to a compounding issue, the patient did not get surgery, so showed up back in my clinic 9 months later, turned down for surgery, now with rest pain and ulcerations, and no one was going to touch him. So just from a technical side, I'll start off with this. So we were able to get across with a 7 French sheath, use a stiff angle glide wire initially to start, and then switch to an 014 to select the SFA. Eventually with TurboHawk, or back then it was TurboHawk atherectomy, and then a second couple pass, and then atherectomy alone, you can see the impact. This was kind of Medina 1. And then balloon angioplasty alone. Thought like this is a good result considering it's my first endovascular case. I'm gonna hold questions till I get through all these so you can see. This is a 70-year-old, because I think they all look at different aspects. 70-year-old with a history of coronary artery disease, no left CFA pulse, failed Pletal, refused surgery, everything's bad on the non-invasive. We'll go with a CTA, you can see how calcified that common femoral is. This was this is the angiogram. You can see the common femoral is out with some reconstitution of a pretty good looking SFA and popliteal. It always amazes me how disease can be focal. In this case, it's really about getting through true lumen to true lumen. Used a pilot 200 wire and then had to push with a little bit of a stiff angle glide wire. So switching back and forth between 014 and 035 nowadays, I would probably use 018 myself. we were able to get into, that's what it looks like with a pilot hole using a 3mm balloon. And then essentially from here, we had to use an 8-French sheath here, and I'll show you why in a second. We were able to wire into the profunda. And then put 2 spiders, because I think prevention is worth a pound of cure. It's all about protection, protection, and protection. 2 spider in both, and then went on to atherectomy directionally. Again, you got to be very careful about this going into the profunda, because you want to cut away from, you don't want to cut your wires. And at the end of the day, that's what it looked like. This patient did quite well. This is before DCBs at this size were available. And it looked pretty good at the end of the day. The patient did well. Healed up, actually was feeling much, much better. And we followed common femoral velocities and did well out to 5 years after I left. So that's what it looked like. This is why you always have to use atherectomy. I think Lawrence Garcia was saying yesterday with directional atherectomy, the embolization rate was super high, almost 12% in the studies. I think this would be foolish not to do this with atherectomy, not to do an EPD. So I think you have to do that. And the last case I'm going to show is someone with heavy calcification. Basically, the profunda was out as well. This is a right SFA occlusion with right common femoral disease as well. We basically crossed the lesion from below and above. This took me about 6 hours to do. I had to use basically 1.5mm coronary balloons initially to try to get the stuff through. It was a nightmare trying to get through from below. This is us going from below and above and below in the SFA. Patient for rest pain and ulcerations. And then to Peter's point, this was shockwave error, so went on to use shockwave. You can see the profunda is out there. It's actually reconstitutes from collaterals from above, which I don't have a good picture of. But that's what it looks like. Chris, do you mind just shutting that off? Thank you. And so final angiography there, I think after IVL showed really, really good results. And again, kind of talking, and we'll get into this in the didactics, what Peter mentioned about was the Medina 111 and kind of where the disease is. I think it's really important to understand where things are and how your patency is going to play out. Additionally, I like to look at it this way. What is the etiology of your common femoral disease? If it's atherosclerotic and there's more calcium, yeah, you may get a great acute success, but it's probably going to be a worse long-term patency versus scraping it out surgically. If it's non-atherosclerotic, i.e., and basically a sealant, some sort of vascular closure device, these patients do really well with endovascular intervention. Great long-term patency. You're not really doing with atherosclerotic. So I think it really depends upon what your etiology is. Predictors of adverse events, I'll just go through, but basically if you're a CLI patient versus a claudicant, critical limb ischemia patients have a tendency to get more stents. I think now with larger superior stents, there's probably more of a tendency to drop a stent in the common femoral if you have to. I've definitely seen Viabonds in the common femoral having, and you can re-access those without an issue. But you really need to worry about the outflow and never, ever, ever compromise the profunda flow. So common femoral disease, I would say definitely not something someone should be doing their first few years out unless you get backed into a corner like I did. You got to make certain that you're in the true lumen if you're going to do this endovascularly. Never compromise profunda flow unless the profunda is already occluded, like in my second case. Got to maximize the lumen, got to use IVUS. We use IVUS routinely. Got to treat inflow and outflow. And remember that calcium inhibits the lumen. No data for atherectomy, no data for scoring balloons, no data for lithotripsy, no data for drug-coated balloon, but it makes sense. And so I think you do what you think is best, and if it was a combination like Peter mentioned about using, IVL and then moving on to DCB or also combination, you got to do what you can. I think that's where IVUS really works out. You can really see how patients are doing real time by doing IVUS and seeing how much luminal gain you get. And with that, I'll stop.
Thank you.
I hope that wasn't Delta calling me back with my flight since they can't. Perfect, awesome, thank you.
It's Microsoft. Great job, Drew.
Thanks,
Those
Chris.
are good cases. What % of the time in your cases would you say you use intravascular ultrasound?
I am now going as I would say 70% now. I wouldn't do a coronary intervention without intravascular ultrasound. I think 5 years from now, we're going to be sitting up here saying, of course we do it. Or maybe it might take 10, but I think IVUS definitely below the knee 100% of the time. Maybe not so much in the common femoral. It does take time. We don't have, it definitely takes more time. It's more of a time factor than every time I use it, I'm like, oh, wow, the vessel's that big? Really? And that includes for iliacs. And so I think it opens your eyes. Sometimes you see stuff you don't necessarily want to see, but it is what it is.
Yeah. I would say time factor for me is why I don't use it more often. What about you, Peter?
Yeah, one of the things I have found, every time I do an IVUS, I always say, God, I should do this on every case because I always learn something.
Yep.
And it's incredible how often you change your treatment plan based on IVUS. And the number one lesson I think that we always learn when we IVUS is that vessels are more calcified than we think they are. And then secondly, they're usually a lot bigger than we think they are. And I can't tell you how many times when I'm working on a common femoral, I'm going to reach for an 8. I've even done 9 millimeter
yeah,
IVL
I've done a 10 millimeter
balloons for
balloon in the common femoral. Yep.
And it's just incredible how oftentimes we underestimate vessel size with angiography. So I've really found it to be incredibly useful. So for, like you, below the knee, I use it on almost every case. But I always use it on every common femoral case because, again, there's more calcium and it's a lot bigger than you think it is.
Would you say even if you have an upfront CTA, you need IVUS? And you're able to measure vessels?
Probably not, but I think one of the things that IVUS adds above and beyond CTA is really being able to evaluate the morphology of the lesion, the wall, the depth of the location and the depth of calcium, which may have an impact in terms of your treatment options. So I still think even with a CTA, I'm going to throw an IVUS down there. The one thing that we also didn't talk about is the role of stents in common femoral. I think on this side of the pond, we really tend to shy away from putting stents in the common femoral. But, there is data for stenting. Jan Gufik, vascular surgeon from Paris, was the PI on that TECO trial, which was a randomized trial of endarterectomy versus stenting. And guess what? At 2 years, there was actually an advantage of endo over endarterectomy. And then Koen de Loos from Belgium was the PI for the VMI study with Supera, and they had a 98% 2-year primary patency rate. Not that I'm advocating we should be stenting common femorals, but it's nice to know that if you need to bail out, that you can. And to Drew's point, if you are going to do that, then Supera is probably the stent of choice so that you can still put a sheath in it later on.
Still not on, buddy.
I have a contrarian view of Peter's. The reason is that the trials that allow randomization to surgical endarterectomy or stenting for the common femoral artery are not the true representatives of the common femorals that are either stented. That's number one. So I think that study is a little bit skewed in terms of its patency, because to qualify for both, you have to be ideally suited for at least one very well. But the kinds of patient we send for endarterectomy are slightly different. So the question is, and then Dmitriy sitting next to me, he wrote the appropriate use criteria. Dmitriy, I don't want to put you on the spot. Remember all the tables? Yes. No. For the common femoral artery. And there is no much level 1 evidence. Now, what is the durability of 111 lesions endarterectomy in calcified for endarterectomy? What is the long-term data? Because that study from Paris that Peter mentioned is a very subset of what common femoral disease in real life should look. And feel free to disagree. I mean, Peter, you're willing to respond again.
Yeah, I think to your point, when we wrote the consensus guidelines on the use of devices in common femoral, the level of evidence is very low. And I think we're all agree that probably the consensus for optimally treating common femoral now, calcified common femoral, is sort of the IVL plus DCB strategy. But I think the data that we have in terms of patency, long-term patency for that strategy is somewhat limited. So I do agree with that statement.
Sanjum and Bala, this is an important area to comment.
So I'm a surgeon, so I always prefer endarterectomy for diseased common femorals. However, I do stent common femorals when there are complications. So like pseudoaneurysms, For aneurysmal disease, like when we treat aneurysms and we do large bore access pseudoaneurysms, dissections, we put stents in the common femoral all the time to treat it. And generally we use Y-bonds because we find that we can access Y-bonds pretty easily subsequently for doing interventions. So I don't recommend it for calcified disease arteries. However, if it is to treat a complication, for example, recently we were called after an impella was put in, and they hadn't pre-closed because the impella was put in urgently and they couldn't pre-close. So I put a stent in the common femoral. So I think there are certain situations where you can put stents. I don't think they're good for calcified arteries.
Sanjum, your comment?
Yeah, I agree. I mean, we worry about the risk of the flexion and fracture, right? But when we follow these patients that have had stents put in under emergent conditions, I followed people 4 or 5 out, anecdotal, mind you, but they tend to stay open. So I wonder if our fears are overblown and we do need more actual data to guide us. Because right now it is case by case, really.
Drew, question back to you. The frequency of the non-atherosclerotic common femoral disease is very low. So let's put it aside. Do you think, given the tools we have in our armamentarium, some of the you showed, is this a right time to ask the question of randomizing real-world common femoral disease and comparing them in terms of long-term patency and/or outcomes?
So I think it's all about who you enroll, and I agree with you. This might be the best time to do that. Obviously, with Hawk, you can get some pretty decent, as you see, some pretty good chunks out. Obviously, deep wall cuts make big issues, as Lauren saw yesterday, and I think it may be that time with IVUS guidance, but you're gonna have to mandate a lot of stuff, right? You're gonna have to mandate, you're gonna have to look at cardiovascular risk, they're gonna have to be able to go to both sides, and then I think the other thing is you gotta mandate kind of certain aspects, making certain that someone just doesn't do one pass with an atherectomy, or maybe with IVL, that they really use IVUS and the patient gets the best therapy they can, and then using core lab adjudication, and then goes on to DCB, and then we can see how these patients do.
Oh, thank you. Peter, rebuttal to what I said, disagree, and then Chris, I want you to also say, because this is an important area, how long are we going to have such an important location with not even close to high-level evidence? So Peter first, and then Chris, and then we'll...
Yeah, in looking at that, in that TICO paper, I mean, what was interesting and surprising was how good the data was, despite the fact that they even used balloon expandable stents in some of the profundas.
Yeah.
And they weren't, they were just using off the shelf. So that, I think, makes that data even more sort of surprising. But again, I will be the first one to confirm and admit that the data is very provocative, but until we have 4, 5, 6, 7, 8 year follow-up data, we really can say very little about it. But I agree. I mean, I think that we now have the tools where we could legitimately do a randomized trial. Now, if we were going to design such a trial, I think it would be really important that we make sure that the operators have all the necessary devices. I think IVL in particular would be sort of front and center, and I think every case should end with a DCB. And in the case of bifurcation disease, I think that the protocol would need to mandate that you would need to treat the profunda as well as the CFA and the ostium of the SFA. And these are not inexpensive chip shot cases. I mean, if you're going to do it and you're going to do it right, it's going to take multiple devices and some patience, and I think it should be IVUS guided.
Chris, final thoughts on this?
Yeah, I agree with everything. Well, first of all, I think at least we can recognize that treating the CFA is not a cardinal sin like it used to be, and there are patients who would do well with that endovascular therapy. Regarding a study, I agree that it is time to do a randomized trial, but as Peter mentioned, you would have to be very specific about how it is treated and who is treating it. And I do agree, IVL would be a necessity, DCB would be a necessity. The question comes up, atherectomy, non-atherectomy, do you mandate what device is used, and then anatomy. I mean, it may be more appropriate not to attack 111s up front, but I know that's something to think about.
Thank you so much. Thank you, Drew.
Thank you.
Our field, and hopefully highlighting the conference, that it is brought together on a common platform vascular surgeons, cardiothoracic surgeons, heart failure specialists, and interventional cardiologists. And consistent with the theme, because I think I want to invite my dear friend and colleague, Dr. Javier Vasquez, to talk about hybrid interventions and all case-based. Javier, floor is yours, and then we are going to ask you some hard questions.
Thank you, Subhash. You know, I was thinking at lunch that I don't know if I've ever been to another meeting where there's this many specialties, and almost feels like I'm spying, you know, on cardiology. But Dr. Banerjee, you know, it's to your credit that you've brokered this sort of conference for us. I think we're learning a lot from each other. Just to segue off, because we're still talking about common femoral disease, I'm surprised at the lack of pre-op image and being inside of arteries 1,000 times now in femoral arteries, same as Bala. You think you know what the lesion's going to look like and act like, and a lot of times you get in there and you would have sworn it was going to be something completely different, and I think that's why it represents a lot of challenges when we treat it endovascularly. But I'm just going to just talk about a quick case that I did with one of our colleagues, Dr. Rossell at Baylor, Heart and Vascular in Dallas, and this just represents a quick case. Disclosures online. Pertinent history was a 67-year-old man with severe claudication, almost rest pain and non-healing left foot wounds with the usual suspects as his comorbidities. We'd had a preoperative CTA that had showed complete left iliac occlusion. There was his ABI was 0.4. There was talk of how we would best treat this, whether a surgical approach, endovascular. He did have some ongoing pulmonary issues as well, so we thought do a hybrid approach. Angiogram had also showed a little bit cheating here because you can already tell I'm operating on the guy, but he did have a left common femoral artery lesion, about 75% as well. So, you know, we chose to do this in a hybrid room with a hybrid approach with myself as a surgeon and Dr. Rossell as a cardiologist. He had known the patient for a long time, had followed him for quite some time, so he really wanted to be involved. And so we tend to take more of a collaborative approach in terms of he wanted to address the iliac lesions and I could address the common femoral lesion surgically. So the clinical challenge for this case is, you know, what is the best approach? Can you do endo first and delay the femoral end art? Probably not the other way around. What's the best room to do it in? And what are the players involved? We chose to do it in a hybrid room. Actually, honestly, we did this case probably in a regular OR with C-arm, but I had provided femoral access. We had trouble going up retrograde, which was surprising, so we actually ended up going up and over and externalizing the wire through the left femoral surgical wound. Then got through there, either created a dissection, there was also maybe some thrombus, so we did some aspiration thrombectomy and finally stented it, kissing technique. And the picture there on the right shows the femoral lesion that underwent endarterectomy. So, you know, I think as far as technical standpoint goes is what do you do first? Sometimes people ask, well, can you just do the end art? Should you do the end art first and then do the endovascular part? Should you do the endovascular part first and then do the end art? My personal feeling is I like to do the endarterectomy first, stick the patch directly, and then go retrograde. You do have to be a little bit careful with that because you don't know what your endpoint plaque looks like, so you have to be careful with dissection and where the wire is. I have a colleague who puts the wire up first and gets through first and then does the end art, and then I have some colleagues that do the end art last. So there are some technical tips and tricks, but at the end of the day, I think good hybrid approach was good to treat his femoral lesion, and just the collaborative approach with cardiology as well in the operating room is possible, and I think sometimes better for the patient. That's it.
Do you have the option to treat retrograde both the common iliacs and also antegrade?
Yes.
At the same time?
Absolutely.
And how do you do that? 2 sticks or reversing the sheath, or what? How do you actually do it through a fresh patch?
No, that's a good question. And we, you know, for us, and Bala had mentioned this in her talk, profunda is king. So, you know, that's the main goal, is to get profunda flow For me, inline flow only if there's non-healing wounds. I think if you're dealing with claudication and you adjust the inflow and you have wide open flow into the profunda, I think we call it a day. But certainly if there's wounds and you're trying to provide inline flow to the foot, it's usually a double stick. Through the same hole, you can always pull out your sheath, clamp your vessels, carefully go into the same opening under fluoro, and then aim your sheath downwards and then address the SFA disease. A lot of times if you have a complete occlusion of the SFA, we'll go ahead and carry our endarterectomy into the proximal SFA, so it makes the wire passage a lot easier. You don't have to deal with that proximal cap, and the wire usually just goes right in. And then you can do kind of a combination inflow, outflow procedure.
And in doing so, you establish a channel into the true lumen of the downstream occlusion, if there is one. Is that?
You hope so. There's a technique to how you would do that proximal SFA endarterectomy. A lot of it is eversion endarterectomy, and then usually perform angiography to make sure that you actually do have flow into your true lumen. And IVUS is obviously very important in that stuff too.
I agree with everything that he said. Usually it's also not necessary to treat inflow and outflow at the same time for most patients, because it's a pretty big surgery to do a common femoral endarterectomy and iliac recanalization. So that itself takes like 5-6 hours sometimes. And so it's better to let the patient recover and then stage the SFA intervention at a later stage instead of treating both inflow and outflow at the same time. And creating that cuff in the SFA also helps you do SFA stenting or intervention in the future, because then it's not a flush SFA occlusion. So we try to do that too.
Well, one thing I've noticed just as being a vascular surgeon is even balloon angioplasty of a vessel, and in rare circumstances you'll go in right after that intervention to operate on the vessel, it induces significant inflammation. I'm always surprised that even with just a balloon angioplasty, what is going on in that area in the intima. So just a side note as to how inflammatory the process is of atherosclerosis and the interventions that we do on these vessels.
Javier, I have a quick question for you. I've had a few cases over the years where, patients have had common femoral endarterectomy, and the vascular surgeons that I work with always try to preserve, centimeter or two of the proximal SFA to allow for access. But I've come across a couple of cases where surgeons outside of my own institution have done common femoral endarterectomy and chosen to ligate the origin of the SFA. So can you enlighten me as to why someone might want to do that?
I have no idea. I mean, I think at this day and age, I think you try to revascularize as much as possible. I mean, and I've always thought, restore anatomy the way the person is intended to be. I don't know why ligating the SFA would be an approach, unless they were worried about some kind of distal embolic area. For vascular surgery, the only vessels that we tend to ligate as part of our treatment would be a popliteal artery aneurysm, where we ligate proximal and distal and do a bypass a lot of the times, if we're not putting a Viabon across it. And that's to prevent distal embolization. So I'm not sure I would understand the reasoning for ligating the SFA. Sometimes if you're doing an aortal bifemoral bypass and you already know your main runoff is going to be the profunda and only the profunda, and this person has long segment occlusion all the way down to the below knee popliteal artery, you may want to transect the SFA so that your bypass lays more coaxial onto the profunda. That's the only reason I can think of, honestly. Bala, what do you think?
I agree with what he said. I mean, it's extremely rare to have to ligate the SFA. The real two situations where that happens sometimes is when it's a redo groin and it's extremely scarred, and sometimes the SFA gets injured, or we take off the adventitia of the SFA while dissecting it in a redo groin, or if there's a groin infection for which we are operating. So that sometimes destroys the vessel. Those are the two situations I can think of where you ligate the SFA, but I don't think anybody intentionally ligates the SFA.
I mean, I think this is a great illustration of hybrid approach and where I think we need to go, right? Because you do have combined approaches that can allow great results. So nothing's particular, but great case.
Interested to hear from our Japanese colleagues. Is this kind of case, obviously here I think the hybrid is the way to go, but is there an alternative of going, radially to treat the left side, left iliac, and then femoral for the right iliac and sort of finish it with the kissing?
Thank you very much. So maybe in this case, I treated this case. I tried to for the transradial approach, so to treat each lesion to bilaterally. Yeah. So sorry, I have a few experience for the hybrid therapy. Maybe I treated with totally endovascular therapy in my daily practice.
I was going to ask you a question as well. When you do have to do kissing stents at the aortic bifurcation and you're on the left radial, are you sticking the right radial or are you going through the groin? If you have to do a CRAB, for example.
Yeah.
What's your approach there?
Transradial and the femoral axis.
Okay.
Yeah.
One last question, just for everyone, clarification. If you put a if you do endarterectomy and put a patch, how early and how soon can we re-access it for, say, large bore access or other percutaneous procedures?
Ideally, we like you not to do that, or not you, but any of us to do that. It depends, the body habitus, of course, how much fat, distance from the skin to the patch, how much dead space was left. We prefer not to access it, but in general, if you had to do it again, you'd want, obviously, the wound to be completely healed and have enough time for that scar to take place, which is probably around 1 to 3 months after the surgery. So that would be my answer if you called me about that question.
Thank you very much.
You're welcome. Yeah, thank you.
All right, and the last presentation is by a gentleman that requires no formal introduction, my much older and a little bit wiser partner, Dr. Chris Metzger.
Thanks for the kind introduction, Chris. And Subhash and Chris, you'll be proud to know I read your email, and so we're going to have one case, and it's going to be interactive with the panel, okay? So this should be fun, and I've got 2 or 3 places that are built in.
That email was mentioned specifically for you because I know your cases, so I told you you have to have one case.
You get
that
one
was
case.
for Chris Metzger
so, you know
specifically.
What? I love you, and because of that, I'm going to listen to you, and we're going to do just that one case. It's a good case. I've got 3 places built in that we can turn over the panel, but Chris, my younger partner, who's smarter and better looking, you can interrupt at any time because you're the moderator. All right. So here are my disclosures, which can be found on the website, won't interfere. 86-year-old female, really sweetheart of a gal, lived independently, had no coronary disease, no peripheral vascular disease. Really didn't have that much history until hip replacements that she may not have needed. She was non-diabetic, non-smoker, life. She had severe bilateral hip and buttock claudication and leg weakness if she walked 10 feet for a while. They replaced both hips. It didn't get better, okay? And then that progressed, it got even worse. And then she had 3 months of progressive bilateral foot pain. There was rest pain, really bad in the dependent position with rubor, ulceration of her toes, some of which were embolic, some of which were ischemic, okay? And she was admitted to an outside hospital, sent over for worsening rest pain and rubor. Here's her ABIs. ABIs 0.17, 0.21, and high thigh indices, which are almost non-existent. You can see the monophasic flow in both common femoral arteries and flat waveforms at both feet, okay? Here's some, we're gonna get some other CT angiogram, but you can see in the aorta, just below the renal arteries, there's just absolutely dense calcium. And it's just below the left renal artery, and on the axial images, you can see it's pretty obliterative. And there's, even in the perirenal area, there's calcium, okay? In trying to really get ready, this is 3-dimensional reconstruction with 3 Menzio, and you can see the calcium coming down on the axial image. There's your left renal artery, and there's just absolutely dense calcium, but it's shortened and it opens up again, okay? And then here's coronal view, again, dense calcium below the left renal artery, and also celiac disease, which I'll show you in a second. So she has that. Here's an angiogram from below. We had a catheter right here, and it looks occluded. But later, there actually is a microchannel. I'd actually crossed it with a wire, but there's a tiny microchannel there, okay? To make things a little more interesting, her left subclavian's gone. and it fills retrograde, and her Celiac was super tight as well, okay? IMA, importantly, is open, okay? So, as we get started, and I'll open it up to you guys in just a second. This is a case summary, did a live case right before we started. Independent, absolutely delightful. You love this lady. And CLTI, debilitating claudication, diffuse disease in the aorta, but also the left subclavian and the celiac. So, questions for the audience and the panel to consider. And I've got the picture down here, although somehow my picture's in there. I was trying to get, you don't want to see me. I was going to give you that as a reminder. But is this a case we should do? Can we do it? Should we do it? Access sites, I'll give you a clue. I'm not going to be single radial. No offense. You could do it in Japan. I can't do it in Tennessee or when this was done or in Ohio. What access sites? How are we going to pre-treat this lesion? Definitive strategy. What are our bailout options? Do we need any? If we can get a couple questions, thoughts from the panel now, if you want, or keep going, you let me know.
This is a good time for us to give you our thoughts. That is why you see this case requires only one case.
Exactly.
We start with Bala. You ladies first. Any comments? Don't say surgery. I think that is not a part of the option. No, I'm kidding.
I think 86-year-old, I wouldn't probably recommend aortic surgery as the first-line strategy. I think you can do this endovascularly as long as, there is a channel there, even though it looks like it's occluded. So it can be crossed, and I would try IVL and probably stenting.
Okay.
Similar approach. I think about, it looks like you have clearance below the renal, so I would think about a covered option here. And you could still use a radio for your visualization if you wanted to, but I think your treatment strategy would definitely be femoral and using sort of a bigger bore so that you have good options, and especially in terms of bailout if you need a coda or something like that, God forbid.
Yeah, I agree. I mean, I think you're going to need femoral approach as your primary approach here. Probably IVL is going to be the way to treat this lesion, even though it's very calcific, eccentric, and ugly looking. But I think the lesion prep is going to be key. I think IVL is going to be, and then probably followed by stenting. Of that area, and we can talk about what kind of stent.
Push a button, Subhash.
My approaches look different. I tell you, there is a good sign in this case that it doesn't involve the bifurcation, because this is a typical female who probably smokes. This narrow bifurcation, if it involves and extends into it, is a big nightmare. So you have something going for you here. My option would be here crossing, of course, IVUSing, and then doing double IVLs. And try not to stent, even if you get through with a decent result, because I do see an accessory or other additional renal branch there. So I think you could stent it, but in an 85-year-old, if you get a good result and you can confirm with the IVUS and there is less pressure gradient, you do 2 IVL balloons together, and there's a strategy of doing it, I would only stent if it is absolutely necessary.
Yeah, I think everyone agrees you're going to have to use IVL here. I'd probably do bilateral groin approach so I could image while I'm prepping for deployment without having to access the arm. You may, after IVL, be able to get away without using a covered stent, but if I'm going to, I would at least consider protecting that renal.
I would do bilateral femoral access. I would also have an access from above. In our experience, we typically have better luck and success in crossing either known or functional calcified aortic occlusions from above. And it's nice to be able to approach one wire from above, the other one from below. And then at least one of those femoral sheaths should be an 8 French sheath, so you can put an 035 Phillips IVUS, get your measurements. IVL obviously is going to be key here. Now that we have the larger L6 balloons, you might be able to get away with, a 12 millimeter IVL. And then I would see what it looked like after that. There is obviously some concern given the proximity of that calcification to the left renal artery. If you get a really nice looking result with IVL, you could consider a bare metal stent to avoid potentially covering that left renal artery. But I think I would have bilateral femoral access, an access from above, and then once you get through IVUS, IVL, and then probably a stent, whether bare metal or covered stent, kind of depends on what your post-IVL result looks like.
Thank you very much. IVL is not commercially available in Japan, so not available yet. Therefore, I'm very surprised at the very popular IVL in US. So in this case, when I treat this case from the femoral access, I put the bigger size smart stent, 14 millimeter smart stent from the single approach, because it's a longer shaft smart stent is not available. Therefore, so femoral access I do.
Chris, one clarification. My rationale for double IVL was not size, but better expansion. And there is some anecdotal data, and you can address it.
So I really like when smart people I respect agree with me a little bit. It makes me feel a little better. So I talked to a lot of colleagues ahead of time. Peter, I may even talk to you about this. This was before a live case we did. So starting here, here's taking a lot of those thoughts into consideration. Here's access from above, an 8 French sheath and a 7 French sheath. And why I didn't raise my hand for 018s in the aorta, this is a time I do think it's a smaller wire is better. There's a microchannel. So these are Command ES from the right and one from the left, okay? And you had to wiggle them a little bit, but they went through. Now, you can see when we got through there, it was hard to get the catheter up there. You see that lesion mighty tight next to the left renal. Importantly, the IMA is going to be an important vessel here because the Iliac is super tight, all right? And so a marker catheter lets you measure the distance between those two to start considering what we may or may not do later, and a couple angles to kind of just see how are we going to see the renal artery later. Next to the lesion, where's the IMA? IVUS was performed. And I like the idea of protecting the left renal, Chris, for a couple reasons, all right? This is from above. We actually wired it and changed out for a Rosen wire, which I usually don't do in a renal, but we wanted to have a bailout option. And if poo hit the fan and this thing ruptured, I wanted to have it ready to go. So what we would do is put a Visi Pro stent in that we could see, and then if we really had to put a graft in there and laser fen it later, okay? So we had all that ready, and so it protected the renal, but it also protected us from that catastrophe moment, and we want to be ready for that. All right. So again, this is 2022. We didn't have the 8, 9, 10, we had the 8s, but we didn't have the 9, 10, 12 by 30 AVL. So next strategy we've already talked about a little bit, so everybody agrees IVL. So back then, 2022, we started with an 8 by 60 IVL. Again, remember there was calcium above the renal, so we had to straddle that. And this, you can see it actually expanded pretty well. And then you can see we got a pretty good lumen there, and the left renal was still open. We actually IVUSed it, talked to the panel a little bit. Could have not gotten bigger, but we decided to go with your kissing strategy. So we offset 2 IVL balloons, offset the emitters, and put them up at the same time to get your better balloon expansion, which we talked about. So then the question is, after this, and I'm going to show you a picture in a moment, I will tell you ahead of time that the lumen was better, but it wasn't normal. The pressure gradient was a whole lot better. Pressure gradient was monophasic nothing to begin with. It was a lot better now. Remember, and I'll show you a picture at the very end of her feet. She had some embolic events too. Some of it was ischemic, some was embolic. So then the question is to the panel, after kissing IVL, what kind of stent? Just briefly, are you a covered stent, stent graft, nitinol stent, DCB? Now we could use an aorta, one that we use for fistulas, at least come up to 10, or just leave it at IVL. Any brief thoughts before we go forward?
I put the bare nitinol stent. I never put the covered stent because I don't like sacrifice some collaterals after the covered stent. Therefore, I put the bare nitinol stent.
Yeah, I think I would want to see what it looked like post IVL and post-IVL, kissing IVL angiogram and IVUS, and let that guide my decision about the stent.
Yeah, I agree. I agree with what Dr. Banerjee said. So you're not obligated to stent here. And the issue that I have with stenting here is you want radial strength, which makes you want to do a balloon expandable, but the way the plaque always is there, you end up with unopposed stent on either side of the plaque because it's not going to fold over and oppose to the aorta. So when you straddle with a bare metal stent, it's really hard to get the top part and the bottom part top more opposed. Usually the top is sitting sort of in the aorta and not opposed.
I would, after angio, do IVUS and do DCB if I can, if it fits the size, or if not, I am not obliged to stent. I already committed that to you earlier, so.
I agree with IVUS and obviously seeing what the angiogram is going to look like after the kissing IVLs. I think I would tend to favor a stent, a non-covered stent, and then have a covered stent as a bailout in case that's needed.
Yeah, I think given the dense degree of calcium, I'd probably lean towards stenting. Obviously, I would want to see IVUS. I want to see where that IMA is, where that renal is, what kind of distance do you have, what kind of stent lengths do you have, diameters, and see what it looks like angiographically. But I would lean towards stenting. Whether it's covered or uncovered would sort of depend on some of those anatomic factors, and go from there.
So I would use a covered balloon expandable stent, VBX specifically, because you get short sizes, you can preserve the IMA, and this is a heavily calcified lesion, and the worst thing that can happen to her is a ruptured aorta, which will kill her. So I would do that.
So for the audience, the last answer was a correct answer? I'm kidding. There's strategies for everything. So that's what I thought. So a couple things. We had all these plans in mind. If there was dissection that extended above the renal, then you can't use a cover stent. Then you may go a nitinol stent to cover it. If it looked absolutely spectacular, maybe nothing. We IVUSed it, took another picture, and again, she had some embolic events and it's calcified, so I really thought we had enough room to use a balloon expandable. Drew.
So, Chris, and I agree, I would have gone with a VBX because you can make 11 millimeters. I think it goes up to 18.
16.
So my point being is, one thing though, in this case, I basically did once, and as soon as I put that cover, the patient became paraplegic from anomalous takeoff, artery being lower than they have to.
Yeah.
That risk.
Yeah, and while that's important, it's a good thing. One zebra doesn't take me to, I don't know, I think about it. So good point to bring up. So you could see the lesion here, okay? And I really thought, she was nice to me on 2 counts, Subhash. She didn't go down the bifurcation, which was very kind. And she also has a relatively short lesion that ended well above the IMA. Okay, so we really thought taking a VBX very close, and before I put this up, panel look, are we in the right place? You can see the IMA over on the arrow with the blue box that says IMA, so clearly above that. Do you like it, your position on the renal? Why not? I thought it looked perfect. I had a panel at Viva all saying it was perfect, but it's a tough one because this is going to make all the difference in the world where we put this thing. Yeah, and again, we had IVUS too, which isn't fair because we had IVUS on a smart map as well that showed us exactly what that darn plaque went to, and we went 1.5 nanometers above where we had to go. So here, well, we had rows and wire there. We had, and this is a shuttle sheet there, so I could do anything I wanted in the renal. Okay, so I thought we were okay there. We could put a balloon there if we wanted. We just chose to leave the wire there and put the stent in, and you can see where it is next to the renal. After IVUS and an angiogram, we did make a non-compliant balloon, and again, we're not going for perfection here, but we got a completely satisfactory. There was it was triphasic signals, both groins shown live. We were happy with this. super happy with that. And everything stayed intact. I'm going to show you this, just a couple things. We're not going to read all this. What I want to show you is before live case 1 and 2 were all the things we had, what was the plan, okay? This, I just want to show you, we had plan A, plan B, plan C for what's going on, all right? So we already had, if it's mild dissection, we'd add a nitinol stent. If it's really bad, then we could put that VisiPro in and maybe put a stent graft and laser fan. If it's really, really bad, put a Reliant balloon up and get ready and put a big stent graft. We had those, we didn't open the expensive stent graft, but we sure had them ready in the rep in the room. And we had a Reliant balloon. So when we opened stuff, I opened the Medtronic sheath and the Reliant balloon. They were prepped and ready to go, okay? And then, we had all this other stuff in the room, not open, because that's a big expense ticket, but they were there.
There are fewer early career operators in this room, but what you highlight is so crucial, even after nearly 25 years of experience. Thinking through all the scenarios, pre-selecting equipment in this case can be paramount. And you justify my request to you for one case. I want to bring one important issue. In our core laboratory, and my team is at the back, we are seeing increasingly for calcified lesions in the iliac, aorta, and SFA, the relevance of wire bias, even for IVL. So it is, even though the issue of extreme or nodular calcification, in my humble opinion, we'll prove it, hopefully in papers, should be decided based on IVUS, not angiography. Just an exophytic calcium does not qualify as nodular calcification, because the definition of nodular calcification is to have a near normal other area. So the expansion of the IVL balloons can happen in the normal area and not do much to the exophytic calcium. And Akiko Mahera in coronary has shown this. Second is the wire which we use to deliver the IVL can be of importance, because the wire bias can change. So increasingly, we are looking in calcific lesions, the issue of wire bias, try to predict it, use IVUS before, after, and in between sometimes, and also maybe use alternative wiring strategies to help improve it. Your comments, do you pay attention to it, Chris?
Very, very much so. And again, we perform in your registry, and I've met some of your folks that handled the data before. Wonderful, wonderful people back in the back, as you acknowledge there. So why don't you raise your hand? Because, I mean, they do and gentlemen, they do a yeoman's job, and it's been a fun procedure going, adventure sharing that with XL-PAD. I mean, and complimenting. So, I couldn't agree more. Obviously going to help. This is, looking at this prospectively, and something like XL-PAD is going to help us. And as a conclusion, kind of thing you listed here, I think this lends itself to hybrid as well. You could have made a case for common femoral endarterectomies for a little bit of extra protection downstream. We did not. We worked with our vascular surgeon who was in the room, didn't want to scrub for the live case, but was right there in case, we got to come. And we had the graft and the Medtronic folks there. And it may not be a popular decision. I think you have to unbelievably prepare for this. But the other thing, for your first and second year, my advice is don't do this case, okay? As much as you may not like me for that, don't do it independently, okay? If nothing else, join somebody else who's experienced to come in. It's not a first or second year case.
Great points.
And for our Steeler fans in the audience, thanks for your attention.
Thank you.
Nice job, Chris. Well, that concludes the session. We appreciate everyone attending. It was a fantastic session. Thanks, panel.